Good. Okay, great. And then hopefully, okay, so now I can actually move them along. So that's brilliant. Okay, so I'm here to talk about the Fontan operation. And we'll talk a little bit about the background, why, in what context we do the operation. We'll talk a little bit about the history of the operation, and then we'll talk about the pathophysiology of the Fontan circulation, because that's very important for you guys to understand. And then we will carry on with the sort of evolution of the Fontan connection and how we do the operation, and then we'll discuss some practical issues, and we'll finish off with outcomes, and then there'll be an opportunity to talk about questions. And like with many of my talks, the idea is not for me to present you the latest evidence or anything like that, but really it's to enhance your understanding of what we do day to day. A real sort of practical guide to the Fontan operation and what happens, on the ground, really. So I think single ventricle work, and this is what the Fontan circulation is all about. So about 8% of all congenital heart disease is sort of categorized as single ventricle. And the Fontan circulation is the final part of the single ventricle pathway, which is depicted in the sort of flow chart here. So we start when you've got a child born with congenital heart disease with either a problem with the right side of the heart. So you have either tricuspid atresia or pulmonary atresia with intact ventricular septum and a small right ventricle, or an unbalanced AVSD with a dominant left ventricle. So essentially, we have a situation in which the right ventricle is inadequate to support the pulmonary circulation. Or you start off with a situation whereby we have an inadequate left ventricle or related structures, such that the left side of the heart is not adequate to support the systemic circulation, such as hyperplastic left heart syndrome or unbalanced AVSD with a dominant right ventricle. And those two groups will undergo different initial operations. Okay, so those that have tricuspid atresia or pulmonary atresia, intact ventricular septum, will undergo operations to secure pulmonary blood flow, or interventions to secure pulmonary blood flow. As we have more and more interventional approaches available now, whereas those with an inadequate left side will undergo essentially a Norwood operation in order to secure systemic blood flow and also pulmonary blood flow, but via some sort of either RV to PA conduit or BT shunt. So that's the first step of the single ventricle pathway. And then the next step is to perform a Glenn or a superior cavopulmonary connection, whereby the systemic venous drainage from the upper half of the body, or upper third of the body, is redirected directly to the pulmonary circulation. And then we come to our Fontan completion, or completion of the Fontan circuit, which is when the remainder of the systemic venous drainage is directed into the pulmonary circulation without going through the heart. And that's what we're here to talk about today. So the Fontan is the final part of that single ventricle pathway, whether you start with a dominant right side, dominant right ventricle, or a dominant left ventricle. The Fontan is the final destination, as it were. So the history behind it is that the operation was initially conceived as a repair for tricuspid atresia. and it was first described in the late 19. I think it was described in the 70s, but first performed in the late 60s, and that was done by Francis Fontan in Bordeaux in France. And the initial classical operation, as he described it and he conceived it, was this. So the situation was that you had tricuspid atresia. So hopefully you can see my cursor, okay? And so there was there was an inadequate right ventricle, yeah, and inadequate pulmonary blood flow. So what he did as part of the operation was that the main pulmonary artery was ligated, okay, and the branch PAs were separated. So there was a division made between the right and the left pulmonary arteries. And the superior vena cava was disconnected from the right atrium and anastomosed to the right pulmonary artery. So what would be a classical Glenn operation. That's how Glenn conceived his operation. And then the ASD was closed, and then the right atrial appendage was used as a sort of a conduit, really, to connect to the left pulmonary artery. But because Fontan felt that he didn't want to have regurgitation from the pulmonary circuit back into the heart, he used an aortic homograft to form that connection between the right atrial appendage and the left pulmonary artery. And then finally, he placed a pulmonary homograft at the inferior cavoatrial junction, okay, so that you had some ability for blood to be sort of unidirectional flow of blood from the inferior systemic venous return into the left pulmonary artery. So that was how the operation was initially conceived. And so what had he done? Okay, so he'd isolated the right atrium, which was now behaving pretty much as a conduit from the inferior vena cava to the left pulmonary artery. And he'd separated the systemic and pulmonary venous return. So by closing the ASD, there was no mixing between the pulmonary and systemic venous circulations. And therefore, the patient or child was fully saturated after the procedure. And this was the flow of blood. So the flow of blood was from the systemic arterial bed through to the venous return, and the venous return would go directly to the pulmonary vascular bed, where the blood would get oxygenated, and then from the pulmonary vascular bed, the blood would pass into the left atrium, and from there the left ventricle, and back into the systemic arterial bed. So therefore, a classic sort of single ventricle circulation where there's only one side of the heart was actually pumping blood into the systemic arterial bed. So that's what he had achieved. But the issue is that the subpulmonary ventricle was excluded from the circulation. So there was no ability for the heart to propel the blood through the lungs. And therefore, the only way that the blood would go through the lungs was via passive flow of that venous return through the pulmonary vascular bed before reaching the left atrium. Not a common atrium in this situation, because the ASD was closed and the right atrium was being used as a conduit, and then from that atrium into the single ventricle. So again, in terms of the pathophysiology, what we have here is a state where the cardiac output is relatively low, and in order to achieve that, we need relatively high venous pressures, because the systemic venous hypertension was needed to push the blood through the pulmonary vascular bed, okay? And the diastolic function of the single ventricle was needed to pull the blood through the pulmonary vascular bed, sort of, as the ventricle was expanding to fill, that would generate a sort of a negative pressure through the pulmonary veins, and suck the blood through the lungs into the ventricle. And the issue is that because the blood had to go through the pulmonary vascular bed to get into the ventricle, we have a situation of inadequate preload. So the ventricle was not being filled adequately, and therefore the cardiac output was relatively low. And it's not, a classical low cardiac output state, but if you're thinking about it in a sort of a chronic way, then overall the ventricle is underfilled, and therefore the cardiac output is compromised. So how do you get around that sort of low cardiac output state? How do you fill the ventricle better? And the way that we do that nowadays, and I'm just going to fast forward a little bit, and I think Fontan also used to do this, was that he used to fenestrate the Fontan circulation. So creating a defect between the Fontan pathway, okay, and the ventricular preload or the atrium. So therefore you get a right to left shunt at atrial level, and you because of that you get mild but significant hypoxia. So the saturations, whereas in Fontan's original operation, the saturations were approaching 100%, because the all of the pulmonary venous return was being directed into the left ventricle, having been through the lungs, and there was no mixing at any level. Okay. Whereas if we fenestrate the Fontan circulation to try and improve ventricular preload, what we end up doing is causing some mild hypoxia because there is mixing at atrial level. Okay. The other effect of having a fenestration in the Fontan pathway, okay, is that if the pressures of the pulmonary artery pressures are transmitted into the Fontan pathway, if they are elevated in any way, the fenestration acts as a sort of a pop-off valve to allow some of that pressure to dissipate, and therefore reduce the overall pressure in the Fontan circuit. Now, having high Fontan pressures is a problem, because those pressures are in turn transmitted into the splanchnic circulation, into the hepatic circulation, and with all of the sort of attendant problems associated with that. So, what were the consequences of Fontan's atriopulmonary connection? So, firstly, as time went on, because of the sort of pressures, there was a development of severe right atrial dilatation, with resultant atrial arrhythmias. As the atrial wall expanded, there was more tendency to develop atrial arrhythmias, and as the atrium expanded and was also more passive rather than sort of it isn't much of a contractile part of the heart anyway, but nonetheless there is some atrial kick as we understand it, and some contraction that is associated with it. But when the atrium was distended because of the way that the blood flow was directed, it was a prelude to thrombosis. The other effects, as I've alluded to, are the effect of increased venous pressure on the splanchnic circulation and on the pulmonary circulation. So protein losing enteropathy was a result of increased splanchnic venous pressure. Plastic bronchitis developed, so that is the formation of casts within the lungs. And in addition to that, there was increased pressure put on the hepatic venous circulation, and many of these things culminated in sudden death. So clearly, there was a need to somehow modify the circulation, and Mark de Laval, who was a surgeon at Great Ormond Street, came up with the concept of a total cavopulmonary connection, rather than the atriopulmonary connection that Fontan had conceived. And what he suggested was that there was almost like a tunnel formed within the atrium, okay, made of Gore-Tex, so that the systemic venous return was a bit more contained, and it wasn't causing distension of the atrium, which essentially was acting as an energy sump. So the energy from the venous return was being dissipated in the atrium, and therefore the blood was not being directed efficiently through the pulmonary vascular bed. So by trying to avoid that, and by constructing a tunnel within the right atrium, more of the energy from the systemic venous return was being directed towards the lungs. So this is an operation that he conceived, and actually it was well received by the sort of congenital community, because of the better sort of energy characteristics that it created. And then that was taken one step further by an Italian surgeon called Carlo Marcelletti, who, rather than having sort of building a Gore-Tex tunnel within the atrium, actually created a conduit between the inferior vena cava and the underside of the right pulmonary artery that you can see depicted in the diagram here, which is essentially how we do our Fontan operation today. So this is termed an extracardiac total cavopulmonary connection, or TCPC. Okay, and this is how we do the operation today. And if you combine that with a bidirectional Glenn operation, then what you have is you have all of the systemic venous return being directed to the lungs. And if you want to create a fenestration that we discussed earlier, what you do is you have to make a hole in the Fontan tube and anastomose that to the atrium. So that's the operation as it is today. All right. So again, I'll just go through that for you. So the classical Fontan, the atriopulmonary connection, was a connection between the atrium and the pulmonary artery. Okay, with the atrial appendage being used as the conduit. Initially, as I described earlier, Fontan had put a valve in that position. Okay, this is a tricuspid atresia, so the valve is closed off, the ASD has been closed, and the pulmonary and systemic venous returns are separated. And then this is Marc de Laval's version of the Fontan circulation, with the construction of a lateral tunnel by placing a Gore-Tex baffle within the atrium to make sure, again, that there is separation of the pulmonary systemic venous returns, and the systemic venous return is being directed into the pulmonary vascular bed. And then finally, we have the final setup that we have now, which is the extracardiac total cavopulmonary connection, as conceived by Marcelletti. So a Gore-Tex tube, either 18 or 20 millimeters, is placed between the inferior vena cava and the right pulmonary artery, which in combination with the bidirectional Glenn leads to a total cavopulmonary connection. So in 1978, when the Fontan operation was sort of taking off, and being and more congenital surgeons were doing around the world, the success from the Fontan operation seemed to be determined by a number of sort of factors. And these were sort of colloquially known as the 10 Commandments, because there were basically 10 sort of prerequisites for a good Fontan circulation. And so this is the list. So, ideally the patients would be aged somewhere between 4 and 15 years. They'd be in sinus rhythm. systemic venous connections would be normal. And those of you that have read more about single ventricles, that's not necessarily the case, and we'll touch on that a little bit later. Ideally we'd have normal right atrial size and volume. Ideally, you'd have adequate pulmonary arteries, and that the mean pulmonary artery pressure as measured at catheter would be less than 15 millimeters of mercury, and also that the resistance through the pulmonary circulation would also be low. Again, ideally, PA distortion was not good, because we want really an easy passage for the blood to be able to flow through the pulmonary vasculature. And in addition to that, you wanted normal ventricular function. We've discussed the impact of having good diastolic function on encouraging pulmonary blood flow in this circulation. And in addition to that, the last sort of the commandments was that you needed a competent atrioventricular valve. And again, that's all about making sure that ventricular function is optimized. However, if you think about it, many of these things are saying the same thing. And actually, the bottom line, when you're considering your Fontan operation in patients, is that really all of those 10 commandments boil down to these two main risk factors. And that what we really need to see is that the preoperative ventricular function is adequate, and that the pulmonary artery pressures are low, okay? And if you've got inadequate ventricular function or high pulmonary artery pressures, both of those are risk factors for poor outcomes following Fontan, okay? So that's the sort of bottom line. So rather than remembering a list of 10 things, it's actually easier to think about two things. And so if you've got a patient with good ventricular function and low pulmonary artery pressures, then they should have a well-functioning Fontan circulation. So as I said, current practice, this is what we do day to day. What tends to happen is that you've got a patient who has been down two stages of the single ventricle pathway. So they've either been through the sort of right-sided or situation where the right side was inadequate and they needed augmentation of pulmonary blood flow in the first instance in the neonatal period, and they've then gone through to a Glenn, or the opposite situation whereby the systemic circulation was compromised and they needed that to be secured, and so they've had a Norwood procedure, and then they've gone down to a bilateral or a bidirectional Glenn. There are other options. There are other types of situation where for the drainage of the superior venous return into the pulmonary arteries. So the classical is a bidirectional Glenn, where a single right SVC is connected to the right pulmonary artery. Sometimes we have a situation where there are bilateral superior vena cavae, and therefore you need to do a bilateral Glenn operation. So both vena cavae have to be attached to their respective pulmonary arteries. And then you have a situation called a Kawashima, where there is a situation where there is interruption of the normal flow of blood from the IVC into the right atrium, in that the IVC has not been formed properly due to the cardiac condition, and actually the venous return from the lower half of the body is being directed through the azygos and hemiazygos veins into the superior vena cava, and therefore the majority of the venous return is actually coming into the heart from the superior vena cava. And in that situation, when you do a superior cava pulmonary connection, we call that a Kawashima operation. So whatever type of cava pulmonary shunt they've had, when it gets to the point that they are starting to outstrip the pulmonary blood flow that they need, the symptoms that they develop is they start to become fatigued, and they start to develop exercise intolerance. And in terms of the signs that we see that their saturations start to drop from the 80s, okay, into less than that. So sometimes into the 70s, and when it's getting really severe, into the 60s. Now, by that stage, we really should have considered augmenting pulmonary blood flow further by doing the Fontan operation. So I think once we see the saturations dropping into the 70s, and symptoms developing, those are the indications to proceed with Fontan. And these patients are typically, 4 or 5 years of age and about 15 kilos, although you can do Fontan operations in patients that are 2 or 3, and they might be 12 kilos. But I think you may struggle in that case to get a decent sized conduit into the space that's available. So you also do need to think about that, but ultimately it will depend on the clinical condition of the child as to when you proceed to Fontan. Surgical steps. So it's a reduced stenotomy because they will have had previous operations. The important steps are to dissect out the aorta, dissect out the right atrium, the superior vena cava. You need to make sure that you free the right pulmonary artery from the pulmonary artery bifurcation all the way out to the hilar branches. And you also need to make sure that the IVC is dissected out. Then you need to go on to bypass, cannulate the aorta, the superior vena cava, and the inferior vena cava. You need to cannulate the inferior vena cava very low before going on to bypass. And the reason that you need to cannulate the inferior vena cava low is that you're going to be disconnecting it from the right atrium. So you need to place a clamp across the inferior vena cava atrial junction, and then actually disconnect the IVC completely from the right atrium. You oversew the opening in the right atrium usually with a 4-row Prolene in a couple of layers. And then you take your Gore-Tex tube, which is either 18 or 20 millimeters, and you take the caudal end of that tube and you anastomose it end to end with the inferior vena cava, you typically using a 5-0 Prolene. The next step is having done that, what you need to do is then control the right pulmonary artery. So you need to stop the blood flow in the right pulmonary artery. So you clamp it proximally or use tourniquets, and also clamp it distally as well. So you have to clamp the branch pulmonary arteries in order to have an isolated segment of the right pulmonary artery, open it on its underside wide enough to accept the superior end of the Fontan tube. Okay, and once you've done that, you can then remove the clips and bring the pulmonary artery back into the circulation, and then come off bypass, and then deal with any bleeding that you might encounter at that stage. So it's a fairly well understood and operation, and I hopefully now you understand the operation as well. So let's talk about some subtleties and what you might need to know as the surgeon that's going to be doing this operation. So firstly, is there an indication? What's the clinical status of the child? What are the symptoms? What are the saturations? Okay, then you need to understand the anatomy. So you need to be able to appraise the echo, and you might rely on your cardiologists to communicate that for you, catheter information, and also cross-sectional imaging. You'll need to know the baseline anatomy, in particular, as you'll be operating on the inferior vena cava. You need to understand the venous connections associated with the heart. So if there is an unusual IVC drainage pattern, so for example, as I said, when you've got azygous continuity, that's an important bit of information that you need to know, because you won't be able to do a conventional Fontan operation if you don't have a conventional IVC connected to the right atrium. You need to also know what was done before, in particular to the pulmonary arteries, because if the pulmonary arteries have been instrumented previously, either bilateral pulmonary artery banding before the child had their NORD procedure, or whether they'd had a Sano versus a BT shunt. So again, both of those conduits would have been anastomosed to the pulmonary artery. Have the pulmonary arteries been augmented with patches? Have they been stented? All of these things are important bits of information that you need to understand before embarking on your operation, because the other end of your Fontan tube is going to be anastomosed to the pulmonary artery. And if that pulmonary artery is small or it's got a stent in it, that's going to make your operation more difficult. And the other thing that you need to know from your preoperative information is you need to plan your sternal re-entry. So if, for example, the aorta is right behind the sternum, you need to know that before going in and doing your operation. So all of this information needs to be appraised, as well as the physiology. So the echo will tell you about the physiology in terms of ventricular function and pulmonary artery pressures, which you'll get from the catheter. Okay, so the pulmonary artery pressures ideally would be below 15 millimeters of mercury and a transpulmonary pressure gradient of below 10. And that is a mean pulmonary artery pressure minus the atrial pressure. So that number needs to be below 10, ideally, okay? Because if the PA pressure is high and the TPG is high, it suggests that there's an intrinsic problem with pulmonary vascular resistance. Whereas if the PA pressure is high, but the transpulmonary gradient is low, it suggests that the atrial pressure is high, and therefore is this a surrogate for poor ventricular function? Is there regurgitation of through the AV valve, or is there restriction at the level of the atrial septum? So, you need to appraise the data carefully because it may be that you need to, do preliminary steps or further interventions before you actually commit this child to a Fontan operation. Because what you don't want to do is take the patient to theatre, do an operation, and for that circulation then not to work. So it's important to understand the physiology. So having thought about all of those things, you need to ask yourself the question, do I need to augment the pulmonary arteries? Am I going to be tackling a stent that's been placed? Is there any atrioventricular valve regurgitation that needs to be addressed? Should I do this at the same time as the Fontan, or is it going to be a bit too much? And should I be doing this as an interstage procedure? So between the stage 2 and stage 3 of the single ventricle pathway, okay? Will I need to fenestrate? So again, if your PA pressures are approaching 15 or higher, the fenestration will be helpful in terms of trying to optimize ventricular function and also to try and act as a sort of, as I said earlier, pop-off valve to try and allow those ventricular pressures to come down slightly. So the pulmonary artery pressures, the Fontan pressures to come down slightly once you've done your operation. And equally, will I need to interrupt antegrade flow into the pulmonary arteries? That's not relevant if they've had a NORD or a Damus K stancil, because the pulmonary artery will have already been disconnected from the branch pulmonary arteries. But in the situation where you've got a dominant left ventricular circulation, such as in pulmonary atresia with or pulmonary stenosis, tricuspid atresia with pulmonary stenosis, for example, you might need to interrupt forward flow to reduce some pressure being exerted from forward flow of blood from the heart into the pulmonary arteries. However, there is a problem with that in that the blood that's coming from the heart has so-called hepatic factor in it, which we don't really know what it is, but it seems to be that blood that is flowing from the liver through the right atrium and into the pulmonary vasculature does have an effect on reducing the amount of arteriovenous malformation development. And if you do get arteriovenous malformations developing, that leads to early desaturation after the Fontan operation. So it's something, again, that you need to consider. This is fine print, but all of these things need to be considered. What about variations? So we talked about the venous drainage, and can I actually do a standard extracardiac total cavopulmonary connection? So are the systemic venous connections normal? Do we have an isomeric patient? So isomeric patients often have problems with systemic venous drainage, and this is a situation here. One of my patients that I've operated on, not and he's due to come for another operation soon. He's due to come for a Glen, but you can see here that this is the SVC and this is the azygos, which is absolutely massive. Okay, because he's got an interrupted IVC. There isn't really an IVC here. Okay, so that all of the blood is going through the azygos. This is the aorta, but this is the azygos and the hemiazygos part, and the azygos is draining up into the SVC. So when I do his Glen, actually it's going to be a Kawashima operation rather than a standard Glen. The connection is the same, but the physiology is slightly different. So if there is no IVC, what do? We do a variation called the intra-extracardiac connection, where the anastomosis is to take the hepatic venous blood. Okay, so you make your anastomosis within the right atrium, around the orifices of the hepatic veins, and take that conduit out of the right atrial wall and into the pulmonary artery. So that's an alternative if you've got problems with venous drainage. Okay, so having done your operation, what about the post-operative period as we approach the end of the talk? We want to extubate the patient early, because the negative intrathoracic pressure that we all generate when we're spontaneously ventilating encourages pulmonary blood flow. There is no pump now, okay? So we need to do everything that we can to make sure that the blood can traverse the pulmonary vascular bed. So the sooner we extubate these children, the better, okay? Patients will need generous volume replacement because the lung vasculature has a high capacitance, and you need to fill that in order to get appropriate preload for the ventricle, okay? And often lactate levels will be high immediately post-op and overnight. But as long as that lactatemia is isolated, it can be ignored and we can continue to give volume. But when you first start looking after congenital cardiac patients, you'll notice that the lactates following Fontans are quite high, 4, 5, 6, 7 sort of range, which is much higher than you'd want in a normal situation, but it's acceptable in a post-op Fontan. And it seems to, by the time you've got the volume status of the patient right, it seems to correct itself overnight. The mediastinal drain can be removed on the first or second post-operative day, but the pleural drains need to stay in for a longer period. And that's because, again, there is a tendency for these patients to develop pleural effusions because as the lungs start to cope with the extra flow and the change in pressure. And so the Starling forces across the pulmonary vasculature lead to the accumulation of pleural effusions in the pleural cavities. And it takes some time for the pulmonary vasculature to adapt before those effusions start to settle, and therefore the pleural drains will need to be staying in for a longer period. So often drains will be staying in for a week, sometimes even 10 days, sometimes even longer before the drainage settles and you're able to take them out. So please don't think when you're looking after these patients that you can take the drains out on the first post-op day because there isn't much blood coming out of them. You'll end up in trouble and you're going to end up having to put drains in for pleural effusions. Okay, so let's look at the outcomes. This is NICOR data for our UK population based over 3 years from 2022 to 2025. And you'll see that the national average of 30-day survival is absolutely super at 99.3%. There's been a couple of only 3 deaths, I think, over the last 3 years. And you'll see that there are some units that are doing up to 80 Fontan procedures over that 3-year time period. So they're not that common, actually. If you think 80 procedures, that's about 25, 26 procedures a year at the largest center. And if you look at sort of more average centers, they're doing somewhere between 30 and 50 a year. So maybe between, 10 and 15 or 10 and 17 patients a year having a Fontan operation. But overall, the short-term surgical outcomes are good, okay, with very few that have not survived surgery. And then what about in the longer term? So there's a good registry that has been set up in Australia and New Zealand that you may have read about, called the Australian New Zealand Fontan Registry, started in 2008, and collecting data from all patients that underwent Fontan or those followed up in that part of the world. And the suggestion is that the majority do survive into adulthood. And for those patients that do survive to 16, and I think there is attrition in the in that period between Fontan, in that sort of 5 or 6 years after the Fontan operation, that's where you probably get the most attrition. But for those patients that get to 16, actually the 40-year survival is between 76 and 85%, depending on their risk factors. So actually not too bad, considering these were all patients that were probably consigned to a fairly early demise. Some patients might require further surgical intervention, even though they've had their Fontan. Traditionally it was always, okay, once their Fontan fails, they'll need a transplant. But actually in this day and age, with all the complexities behind transplantation and the lack of donor organs, actually transplantation in the context of Fontan is actually quite rare. And therefore, they might end up having high risk conventional surgery. It will be a 4th or 5th time restenotomy. And the sort of operations that they'll need are systemic atrioventricular valve repair or replacement, or aortic valve replacement. And if you look across to the CT that I'm showing here on the right hand side of the screen, this is one of my patients from earlier in the year. So he was born with pulmonary atresia, intact ventricular septum. He'd gone through a single ventricle pathway, and he, as often these patients had, has got a very large aorta that you can see here, and you can see that it's very close to the back of his sternum. So the re-entry was going to be difficult, and what the indication for surgery was that he needed an aortic valve replacement. He had significant aortic regurgitation, so we went in and did an aortic valve replacement for him, and he had a bit of a torrid time in the intensive care unit, but eventually made it home. So I think that's it. And time for some questions if you have any.
Thank you so much for such a fantastic talk. If anybody's got any questions for the next couple of minutes, we've got one from Anna. I was
Should I stop
wondering,
sharing?
it's up to you, yeah.
Yeah.
Uh, Thank you for a brilliant talk. I was wondering, are these patients at increased risk of PA stenosis?
Of PA stenosis. Not because of the Fontan, but because usually when they've had previous operations, we may have instrumented the pulmonary arteries. So, for example, if you're dealing with, let's say, a child with hypoplastic left heart syndrome, but they're of a low birth weight, your initial strategy might be to band the branch pulmonary arteries, and you might leave those bands on for up to a few months sometimes, not always, but up to a few months. And if you do that, you end up sometimes with scarred and stenosed pulmonary arteries, which will need to be augmented. But the problem with augmenting pulmonary arteries is that sometimes you don't get it completely perfect. And so there is always a possibility of pulmonary artery problems, and they may need stenting in the future. And then if you've got stents in the pulmonary arteries, then you may end up with relative stenoses because of in-stent restenosis, etc. So assessing the pulmonary arteries when you're doing a Fontan operation is really important.
Uh, Thank you, Mr. Musa from Taha. And then we have a question. For trainees, what do you think are the common pitfalls in learning the procedure, and how would you overcome them?
Well, I mean, I think it's all about uh, volume, isn't it? And the fact is that in most centres, if you're doing, let's say 10 or 15 a year, and there are four consultants in each centre, that means each consultant is going to be doing three or four of these operations a year. So how do you reconcile that with then trying to train people to do the operation? And so, like many things in congenital heart surgery now, your training, although you are you're observing a lot and you're participating in the operation, but actual hands-on training often will occur as a mentored consultant, rather than as a sort of a trainee in inverted commas, as it were. So, but I think actually as an operation, it is technically not that demanding. Okay, you're operating on a bigger child. It's big anastomoses. I think the most important thing is that you sort of make sure that you kind of set yourself up and you measure the conduit well, so that you've not got a kinked conduit, you've not got problems with that. So there are things that you can learn, and there are also things that you're going to develop in your own practice.
Thanks. Somebody said, "Thank you for an excellent talk, Mr. Musa. I was wondering where you see the future of Fontan procedure going, and how the Fontan procedure that with surgeons of the future may differ from today's Fontan procedure. Thank you."
So what was that question again? Where do I see it going in the future?
Yeah.
Um, I'm not sure actually. I mean, it's already evolved quite significantly in the last, since it was first conceived over the last 30 or 40 years. I don't know what the next step is really. Um, I think we do more. I think what we will see more of is that we're going to see more and more patients that are Fontan survivors that are going to need complex surgery in adulthood, and I think that's what we're going to be seeing a lot more of, and that's what you guys are going to be seeing a lot more of, when these patients need their systemic atrioventricular valves dealt with and their aortic valves, etc. So, and this surgery is not easy.
That links into the next question. Great talk. Thank you, Mr. Musa. For the failing Fontan adults, is there a role for ventricular assist devices?
Well, is that from Alex?
Yeah.
That's his pet. That's his pet subject, I think. And um, will you tell me, Alex? You can unmute.
I think
Is
just
he
have
not?
to
He's not.
co-host.
He's muted.
Just have to make him co-host, I think.
Yeah, no, no, okay, no, no, don't worry. So, I mean, I think, look, the issue is that I'm not sure whether we have devices that can cope with the hemodynamics of the Fontan circuit. I think, and that's the bottom line. That they're not there. I think they're not developed yet. Probably knows more, and he may want to put something in the chat. Um, but I think that's the real sticking point, to try and get a device that is actually able to handle the sort of slightly strange hemodynamics of the Fontan circuit is the issue here.
Um, at what point would you consider conduit replacement in a Fontan patient?
Uh, as in to replace the actual conduit, the Fontan conduit.
Um, doesn't mention so, but I
Yeah,
presume.
I mean, I guess that's what they're talking about. I don't think it's necessary actually. So when you generally try and get the biggest conduit you can fit in, and so that's usually enough. So for example, when I operated on the 24-year-old that had the Fontan when he was 5, that was completely adequate for him. There was no issue with the sort of function of his Fontan circuit at all. So it's unusual I mean, I don't think I've ever even heard of anybody having to upsize a Fontan conduit.
I think Aisha's got a question.
Thank you so much for a great talk, Mr. Musa. I was wondering if you see a role in kind of simulation of Fontans and some of the work like Boston's been doing with predicting how some of the more complex Fontans are going to go. Do you see that coming to the
Well,
UK in the
I think that's right. I mean, the more with we're trying to predict what outcomes, and the more data that we have and the more models that we can create, I think that our decision making is going to become slightly more nuanced, isn't it? With the more information that we've got. So I think everybody would welcome an ability to be able to predict poor outcomes. And so I think if there is a tool that we can use to do that, that's reliable and robust, then I think everybody would welcome that.
Thank you.